Okay, let's unpack this. We're taking a deep dive today into one of the, well, most common skin findings you'll see, seborrhoeic keratosis. Think of this as a high-yield revision session.
Absolutely. We're aiming to boil down what you really need to know about these lesions for your exams and for practice, what they are, why they show up, and crucially, what they aren't.
Right, because that difference is key. So, first things first, what exactly is a seborrhoeic keratosis?
Okay, so basically, they're very common, totally benign skin growths. The really classic thing is how they look, often described as having a stuck-on appearance.
Stuck on, right, like it's not growing from the skin but placed on it.
Exactly. And they're typically raised, can feel a bit waxy or sometimes quite rough, almost warty.
Hmm.
Color-wise, they vary a lot, light tan, brown, even very dark brown or black.
Got it. Common, benign, stuck on. So why do people get them? What's the etiology, the risk factors?
Well, the precise cause isn't fully known, but age is definitely the biggest factor. They just become much more common as you get older.
Okay, age. Anything else?
Yeah, genetics plays a part. If your family has them, you're more likely to get them too. Sun exposure is often mentioned, maybe as a contributing factor, though perhaps not as directly causative as for, say, actinic keratosis.
Interesting. And you sometimes see them alongside things like dermatosis, papulosa, nigra.
That's right, those small dark bumps, often seen on darker skin types, seeing those might increase the likelihood, suggesting some shared predisposition or pathway.
So age, genes, maybe sun, other skin findings. What about the pathophysiology? What's happening at the cell level, roughly?
It's essentially an overgrowth and abnormal proliferation of the epidermal cells, the keratinocytes. There are some gene mutations linked, like FGFR3, but for practical purposes, you just need to know it's a benign overgrowth causing that typical appearance.
An overgrowth of normal skin cells. Just
Yeah.
messy. Okay. Now, this feels really important clinically, especially for exams. The differential diagnoses. What else could it be?
This is absolutely critical because while SKs are harmless, they can sometimes look like more serious things. You have to be able to tell the difference.
So, what are the main ones to worry about?
The big ones, the ones you cannot miss, are primarily melanoma, especially pigmented nodular melanoma, and sometimes pigmented basal cell carcinoma. Actinic keratoses are another differential, though they usually feel rougher, more like sandpaper, and are slatter.
Right. Melanoma and BCC are the big concerns. How do they differ generally?
Melanomas often have more irregularity, the asymmetry, border irregularity, color variation, maybe recent changes. BCCs might look pearly, have tiny blood vessels, or even ulcerate. SKs tend to be more symmetrical, well-defined, and have that classic stuck-on, maybe slightly greasy or warty feel.
That stuck on feature keeps coming up. So, if you're unsure, especially if there are worrying features, biopsy.
Exactly. Diagnosis is usually clinical, based on that typical look. But if there's any doubt, particularly if you're thinking melanoma or BCC, then a biopsy is needed to be certain. Don't rely solely on the clinical look if features are atypical.
Okay, clinical diagnosis usually, biopsy if unsure. What about management? Do they need treatment?
Generally, no. Since they're benign, treatment isn't medically necessary. It's really only offered if they're causing problems like itching, catching on clothes, becoming inflamed, or if the patient finds them cosmetically unacceptable.
And if treatment is wanted,
Options usually involve removal by a dermatologist, things like cryotherapy, freezing them off curettage, which is scraping, electrosurgery, or sometimes laser. Pretty straightforward procedures usually.
makes sense. And prognosis, long term.
Excellent prognosis. They're completely benign, non-cancerous. Removing one gets rid of that lesion, but people prone to them will likely develop new ones elsewhere over time.
So they can recur, or rather, new ones can appear. Are there any complications to be aware of?
The complications aren't from the SK itself being dangerous, but usually from irritation or trauma. Like if they constantly rub on clothing, they can get inflamed, itchy, bleed. Picking at them can also cause bleeding or, rarely, infection.
Okay, so mostly nuisance factors. Right. Wrapping up then, benign, common, stuck-on appearance. Key differentials are melanoma and BCC. Diagnosis is clinical unless uncertain. Treatment only if symptomatic or for cosmetic reasons.
That's a great summary. Benign, but always consider the differentials.
For more free MSRA revision resources, visit freemsra.com, and for the full premium revision toolkit, head to passthemsra.com. So, final thought here. Given how common these are, but how crucial it is not to miss something serious, what's the single most important question you should always ask yourself when looking at a lesion that might be a seborrheic keratosis?